but I'm going to provide a quick background, get into the objectives, splash over the methods, give you some of the main results and our conclusions. So just quickly as background, at the time of the review, there was an estimated 5.3 million under 5 deaths globally, with more than half of those in sub-Saharan Africa, so 3.3 million, and 28% of those occurred in Central and Southern Asia. Infectious diseases were the leading causes of under 5 deaths globally. Pneumonia was at 15%, diarrhea 8%, malaria 5%, and newborn sepsis 7%. Nutrition-related factors contributed at least 45%. That's based on the UN Interagency Group for Child Mortality Estimations, the 2019 report. In the 2000s, WHO and UNICEF developed an approach called integrated community case management to bring treatment services for children closer to home, building on and extending the strategy for facility-based integrated management of childhood illness, or IMCI, that was developed by WHO and UNICEF in the mid-1990s. So what is ICCM? It's an approach to providing integrated case management services for 2 or more illnesses, including diarrhea, pneumonia, and malaria, with the latter in malaria-affected countries, among children under 5 at community level, i.e. outside of healthcare facilities, by lay health workers, also known as community health workers, where there is limited access to health facility-based case management services. ICCM is considered an equity-focused approach in that it is primarily implemented in rural and hard-to-reach areas with limited access to facility-based case management services. And as I noted before, it's an extension of the IMCI strategy, which is case management services provided at facility level. The components of ICCM, so there are 3 main components of ICCM. The first component is a training and deployment component, including interventions with the main purpose of increasing access to integrated case management services for children under 5 by training lay health workers on the generic or adapted WHO UNICEF guidelines for integrated case management services, and deploying them where facility-based case management services are limited. The second component is a systems component, and that includes interventions with the main purpose of improving implementation of ICCM by strengthening health systems, organization, and management, including supervision, information systems, and M&E, and supply chains. Then there is a communication and community mobilization component, which includes interventions with the main purpose of promoting good practices for health and nutrition and generating demand for case management services for ill children through communication and mobilization of communities and caregivers. But who provides ICCM? ICCM providers may include any lay health workers, paid or voluntary, who provide ICCM services for children under 5, that is integrated case management services for 2 or more illnesses, are trained on ICCM but have received no formal professional or paraprofessional certificate or tertiary education degree. It includes those who receive a certificate on completion of their ICCM training, but excludes healthcare providers who receive pre-licensure or post-licensure training certified by a professional body such as a nursing or midwifery council. And just to note, just to say that as community health workers start to organize worldwide and they start to develop associations, we might have to change that definition. Packages of services, integrated case management services for 2 or more illnesses among children under 5, as I've said before, including the assessment and classification of the child's condition using a simplified IMCI adapted algorithm by WHO and UNICEF. The referral of cases with general danger signs and other complicated cases, provision of treatment for the following: non-severe pneumonia with oral antibiotics, non-severe diarrhea with oral rehydration salts, or ORS, and zinc, non-severe malaria with ACTs in malaria-affected countries. It may also include case management services as above for neonatal sepsis, newborn local infection, and severe acute malnutrition. The objectives of the review. What we wanted to do was to assess the effects of the integrated community case management strategy or approach on coverage of appropriate treatment for childhood illness by an appropriate provider, quality of care, caseload or severity of illness at health facilities, mortality, adverse events, and coverage of care seeking for children under 5 in low and middle income countries. The types of studies, this is a lot on the slide, so I won't go through it all, but it included broadly the RCTs, or randomized controlled trials, including cluster RCTs with at least 2 intervention sites and at least 2 control sites, non-randomized trials, again with 2 intervention and 2 control sites, CBAs with at least 2 intervention sites and at least 2 control sites, in which allocation was not done by the study investigators and outcomes were measured both pre and post for both groups. ITS studies with a clearly defined point in time, I should say interrupted time series studies with a clearly defined point in time when ICCM occurred, and at least 3 data points before and after the introduction of ICCM, as well as having met the EPOC standard criteria for methodological quality of ITS designs. Repeated measures designs, those ITS studies where measurements were made in the same individuals at each time point. For all of our studies types, we restricted to LIMICs as categorized by the World Bank, and there was no restriction by language, publication status, or date of publication. Comparisons we looked at. So we compared ICCM with usual facility services, facility treatment services without single disease community case management. We also compared ICCM with usual facility services plus single disease community case management. And in this case, we found one study that had this case where they were also providing community case management for malaria. We also suspected that effects would vary depending on a number of program and contextual factors, so we attempted to look at sub-analyses. Primary outcome measures included coverage of appropriate treatment by an appropriate provider, quality of care assessed by adherence to standard or adapted WHO UNICEF ICCM practice guidelines, caseload or severity of illness at health facilities, measures of mortality, adverse events, and secondary outcome measures included coverage of care seeking to an appropriate provider of treatment services and coverage of care seeking to an ICCM provider. I'll just quickly go over this. We conducted the review according to protocol, following Cochrane guidance and EPOC guidance. We assessed risk of bias following the Cochrane and EPOC guidance, analyzed results separately by type of study, and used grade to assess the certainty of evidence. So I'll get into the main results now. So of over 5,300 records, we included 7 studies, of which 3 were cluster RCTs and 4 were CBAs. 6 of the 7 studies were in sub-Saharan Africa, and 1 study was in Southern Asia, specifically Northern India. 6 studies compared to usual facility services, and 1 study compared to usual facility services plus community case management for malaria. The ICCM components and inputs were fairly consistent across the 7 studies. Few studies included interventions for the payment of ICCM providers or training of facility providers on ICCM or IMCI or IMNCI as part of the training and deployment component. Few studies included interventions to improve health information systems, use of ICT for ICCM or M&E as part of the systems component. And few studies included interventions for improving newborn health, for example, newborn sepsis and newborn local infection. Our results compared to usual facility services. We conclude that we are uncertain of the effect of ICCM on coverage of appropriate treatment from an appropriate provider for any ICCM illness with an RR of 0.96 and 95% confidence interval that crosses 1. There were 2 CBA studies and very low certainty of evidence. ICCM may have little to no effect on neonatal mortality. The hazard ratio was 1.01, 95% confidence interval that crossed, that went from 0.73 to 1.28, 2 trials, and low certainty of evidence. We are uncertain of the effect of ICCM on infant mortality. The hazard ratio was 1.02 with a 95% confidence interval that went from 0.83 to 1.26, including 2 trials and very low certainty of evidence. and under 5 mortality. The hazard ratio was 1.18 with a 95% confidence interval from 1.01 to 1.37 and very low certainty of evidence. And that was from one trial. Further, compared to usual facility services, ICCM probably increases coverage of care seeking to an appropriate provider for any ICCM illness by 68%. The RR was 1.68 and 95% confidence intervals went from 1.24 to 2.27. There were 2 trials and moderate certainty of evidence. None of the studies reported on quality of care, severity of illness, or adverse events for that comparison. Now comparing to usual facility services plus CCM for malaria, we concluded that we are uncertain of the effect of ICCM on coverage of appropriate treatment from an appropriate provider for any ICCM illness, very low certainty of evidence. ICCM may have little or no effect on care seeking to an appropriate provider for any ICCM illness. The RR was 1.06 with a confidence interval going from 0.97 to 1.17, 1 trial and low certainty of evidence. None of the studies reported quality of care, caseload, or severity of illness at health facilities, mortality, or adverse events for that comparison. Our conclusions. We concluded that ICCM probably increases coverage of care seeking to an appropriate provider for any ICCM illness. However, the evidence presented here underscores the importance of moving beyond training and deployment to valuing ICCM providers, strengthening health systems, and engaging community systems. Given the very low to moderate certainty evidence for all reported outcomes, further research is likely to have an important impact on our confidence in the estimates of effects and may change the estimates. Moreover, evidence was not reported for 3 primary outcomes: quality of care, caseload, or severity of illness at health facilities, and adverse events. So research is needed on those outcomes. The implications for practice. So we can say that integrated community case management is a complex intervention, and there was important variation in the components and inputs included across studies, particularly with regard to inputs for training and deployment, for example, the training of facility-based providers, payment of ICCM providers, and strengthening the health system, so the systems components. There was also important variation regarding inclusion of interventions for improving newborn health, newborn sepsis, and newborn local infection notably. And we can say that although the complexity made it infeasible to disentangle the effects of one component versus others, it really did underscore the need for policymakers and program managers to engage with that complexity. And it also underscored the importance of ensuring that all components and inputs of ICCM were adequately addressed in the given context, particularly the neglected components of training and deployment, as well as the systems components that were less prevalent in the studies that were included. The evidence presented here underscores the importance of moving beyond training and deployment to valuing ICCM providers and strengthening health systems and engaging community systems. What are some implications for future research? Well, it was the first systematic review of ICCM, so it filled an important gap, but given the very low to moderate certainty of evidence for reported outcomes, further research is likely to have an important impact on our confidence in the estimates and may change the estimates, so there's room there for further research. Moreover, there was no evidence for 3 primary outcomes, so further research is needed on those. And future research could also aim to identify effective ways to improve ICCM design, implementation, monitoring, and evaluation within the context of broader primary healthcare and community health systems, considering all of the ICCM components and inputs, and with particular attention to gaps identified in the studies included in this review. So before we end and take questions, I just want to acknowledge the support from EPOC and Cochrane Norway. Really want to thank the support from our editors, Celeste and Liz Paulson, as well as Simon Lewin, and the peer referees, Patrick Owen, Witness Mapanga, as well as especially Mara Johansson. She was our search specialist from EPOC, who did a lot of the heavy lifting on the on the search strategy. So thank you, special thanks to Merit. And just want to also thank Elizabeth Royal and the Copy Edit support team. So thank you, and we can take questions. There's a link to the review, also a link to the summary of the review. You can email me with questions at the email provided. I'm also on Twitter. So thanks very much. Simon, over to you.